for this month, April. As always, we are here in the last Wednesday of the month. Today, we are very, very happy, and we really appreciate that finally Tareen Davut could be here with us. Thanks, Tareen. We know that you are making an effort because you are traveling at the moment. She's in South Africa, and so the talk will be done from there. So we really appreciate. Thank you so much, Tareen, and received her degree in electrical engineering from the University of Witwatersrand in South Africa. And then she began her career in the corporate world. She worked in a variety of industries, but then because of her own illness, so she decided to move into academics. She wanted to use her technical background to improve healthcare with the focus on the field of medical imaging. And she's at the moment actually doing a PhD here at King's as a Drive Health student. She's being supervised by Dr. Andrew King and Professor Reza Razavi and Dr. Esther Puyol Anton. And her PhD project is aiming to develop an artificial intelligence decision support tool that can use big data to assist cardiologists in making better and trustworthy decisions about diagnosing and treating cardiovascular patients, which looks absolutely amazing and interesting to us. So we are really, really looking forward to hearing your talk today. Just telling the audience that we will be first doing the talk as always, and then when Karina finishes, you will be allowed to make questions. You can just type them in the chat, and I can facilitate them, or you can just raise your hand and open your microphone. So Tareen, I leave in with you when you're ready. Thank you.
Perfect. Thank you so much. So I think there's not too much to say with the introduction. I think you did a really good job. Thank you so much. So I think today I'm going to be talking a bit more about my work. So that's, as mentioned, it's to do with trust, in particular for cardiac deep learning models. And I'll talk specifically towards uncertainty awareness training. And that's something that I focused a lot in a paper that we had published last year. So maybe I think I already have a bit of the journey already spoken about, but I'm from South Africa. And if you don't know too much about it, at least you should remember that we won the Rugby World Cup last year. That's what I like to say. So I have 4 years of celebrating. As mentioned, my background is electrical engineering. And in 2015 was where I have my big bang, so to say. And that's where I decided to come back into academia. Initially, I studied in hematology, looking at machine learning methods that could help within South Africa differentiate things like TB and HIV. And then going on to look for funding, I came to King's, and that's what brought me to the present day, where I'm looking at cardiac deep learning models. And then, as I say, for the future, it holds lots of opportunity and hope. So in terms of the overview, I in particular look at MRI images, building these classification models, and then, some sort of classification outcome, often as binary. But what I've been looking at is how can we actually trust these predictions that are produced from these models? So in general, deep learning models, are quite complex, and trying to translate them and make them decision support tools that can actually use in the clinical environment, we need to trust them. And that's the basis of my work. And I particularly look at the confidence and uncertainty in the predictions. So maybe we should start off by saying why, for instance, our simple normal AI models are not sufficient. And if we generally utilize medical imaging classification as the explanation here, we have images that we use as input data. We develop these models. Here I have a neural network. And then when we move to the evaluation stage, for instance, if we take one of these patients and we say we know that they have a ground truth disease D, we evaluate them, we get probabilities per each of the classes that we had initially trained with, and we have a final classification. So in this case, we could say, yes, it did classify as disease D, and then we know the ground truth was also disease D. So we say, okay, there's a good balance there. But the problem is often we don't look at the predicted probability or this confidence that we have in the evaluation stage versus the final classification or the accuracy. So this relationship is actually termed calibration. So maybe to explain this further and why it's important, normally we often see these prediction-only models where we just say, a model or has a certain level of accuracy. And in those cases, for instance, if we were looking at cardiovascular disease and trying to predict, if a patient has cardiovascular disease or not, and we had a trained model, we can say, let's see how it compares against a clinician. So if a clinician had to make a human assessment on an image, They would, for instance, based on their experience and also their knowledge, say they're fairly confident. So, for instance, they would be 75% confident. And then if we had to compare that against an AI model that we had trained, it could also, tell us it has CVD. So in this case, it did. And in this case, this would be actually good because your outcomes actually match. The problem happens actually if you had to pass one of these patients through the model and it had to have a different outcome to that of what the clinician would say, the person, just by looking at the image, saying that the person has cardiovascular disease or not. So in this case, this could be quite misleading for a clinician because the outcomes don't match. And in this case, the clinician could actually change their mind. So this would have the opposite effect of what we want to do with these AI models. So then we say that predictions can only be used if we actually include some level of confidence in our models. So here again, we have the same scenario, but we say we've calibrated the model. So if we go back, or think back to the first slide I presented, the predicted probability does match the accuracy of the model. Then in these cases, even when the model predicts an incorrect outcome, they do so with a very low confidence. So in this case, you can actually utilize a model that's built like this as a support tool, and the clinician can then utilize their expertise or their experience to make a final call. But therefore, if you don't have a very calibrated model, i.e. that probability and the true correctness do not match, in those cases, you could have the outcome where you actually have a highly confident incorrect prediction. So again, you're left with the same problem where the clinician could be misled and have the incorrect decision for a patient. Therefore, we say confidence can help only if your model is calibrated. So three main aspects of my work has been that I've been trying to look at confidence predictions, looking at measuring uncertainties and different methods, making sure that we have calibrated models and putting that together such that we can have a decision support tool and ultimately move towards this idea of having trust with our deep learning models. So in terms of the work and how I brought that into my work, one of the main papers to which I'll explain now is uncertainty-aware training, to which I was trying to improve model calibration and specifically for classification models that utilize MR images. So as an introduction, what we tried to do was kind of create these novel uncertainty awareness strategies. So incorporate uncertainty into our models as we train them, but also go beyond that to try and think what kind of performance metrics we need to utilize to evaluate these models in terms of calibration. And then if we could also measure uncertainty, pass it through these models and look at how that affects your performance in terms of calibration, and also looking at, how can we actually choose our models correctly, or is there a correct way? So those were kind of the questions that we were looking at as well. So again, a background, as I mentioned, it's the MR model images that I put into the classification model. And with uncertainty now, often you'll see, and there's a lot of research going into this now, they talk about two kind of major aspects of uncertainty. The first one being aleatoric, so that relates to the data. So your input images, that could be due to the noise. So those you can't really change. Maybe you can add more data, but that's something that's been looked at. But epistemic uncertainty, which is your model uncertainties, usually you can make more changes there because that's actually how you develop the model and the various variables that are used to train the model and to give you a final train model that you evaluate. So currently there's lots of established methods to quantify the estimates of uncertainty, but I'll speak to some of those after the slide. I just want to say there's also, I think currently maybe the terminology used for uncertainty and when we have a lot of our papers might not always be consistent. So that's something we always need to consider. So in our work, we looked at uncertainty in terms of the confidence or the probabilities that you usually get from the softmax layer, and the complement of which would be uncertainty. So that's something we did because a lot of this work was preliminary work to investigate calibration and evaluate it in terms of all these different metrics that are available to us. And the fact to always remember that between segmentation, classification problems, and regression problems, even that uncertainty value and how you quantify it's going to be different in what you utilize. So that's just something I'll probably say upfront because it can get a bit confusing from some other papers that we read. But the main idea of our work was that we were trying to reduce really overconfident incorrect predictions and try and promote or find ways to increase the confident correct predictions. So in terms of going back to uncertainty in deep learning models and the various methods, there's lots that are currently being utilized. Here, there's quite a big map of it, but essentially, I think a lot of people might have heard of ensemble methods. That's creating many different models, averaging over that and looking at the uncertainties and quantifying those deviations. Single deterministic networks, that's something that I've also seen coming up quite relatively new now, where you have a single pass and kind of having uncertainty as its own standalone value. Bayesian methods, some more probabilistic methods, also quite used in the literature as well. And you have test time augmentation methods. So it depends on what type of uncertainty you want to utilize, what type of architecture you have, will depend also the type of method used to quantify uncertainty. So within our work, I have it now in silos, the deterministic methods, Bayesian, ensemble, and test time data augmentation. I was looking at Bayesian neural networks, and that was allowing me to look at the epistemic or model uncertainty. And I had, here I just talk about the fact that Bayesian is your probability distribution of the model parameters, so just a bit of extra detail. But in terms of the toric uncertainty, I was using test time data augmentation, and that was suited to the model I was using, and you'll see that in the slides to follow. So here with test time data augmentation, what it allows me to do is that I can generate multiple predictions in my model, and that allowed me to put that in my input data that you'll see now. So with the input data and looking at that in terms of uncertainty, let's just understand maybe a little more of the architecture of the models I was using. So as you know, I'm using medical images, but here I use cardiac MRI, and in particular, often you'd have short axis, 4-chamber or long axis. I was using the short axis images. And I was interested in the segmentations of the right ventricle, myocardium, and left ventricle. So in terms of the uncertainty in my segmentation network, so in this first aspect, this is where I was able to look at my data uncertainty, and I did that through this test time data augmentation. So as you can see, you'd have multiple samples, or in my case, multiple segmentations that I would utilize. And for my model uncertainty, that was slightly different. I was using a Bayesian approach as for my previous slides. And in I'm sorry, I see there's a message. Oh, sorry. Okay. Sorry about that. So with my model uncertainty, I was using something called a variational autoencoder, and that allowed me to have this, it allowed me to use a Gaussian distribution, and therefore I could utilize it for sampling for the same patient, many different samples. So that allowed me to look at variance. And in that case, then it allowed me to then utilize that latent distribution, utilize the ability to sample, but also what it allowed me to do was, because of the nature of a variational autoencoder, it allows you to create a lower dimensional embedding. As you can see there, it allowed me to then create my final classification model. So then in terms of uncertainty, and if you now put off that information, because I think I'm just putting quite a bit of information all at once on you, the idea was that I needed to have a segmentation network, and that's where I would have my leptoric uncertainty, and where I can estimate that. I would need my VAE network, and that's where I would have my Bayesian or epistemic uncertainty. I have my classification network, and ideally what I'm looking at is the test time predictive uncertainty and evaluating in terms of calibration. So then where does this uncertainty aware training fit in? So in terms of uncertainty aware training, you'll see in the first kind of top line here, your normal training is when you're actually looking at accuracy only. But uncertainty aware training is where you're trying to add this calibration metric through some loss or some weighting, such that ideally what you're trying to do is minimize the confidence of incorrect predictions, and you're trying to maximize the confidence of correct predictions. So then in terms of the approaches, so maybe this, I was trying to find different ways in which I can show you this. I would always have a base model. So my base model will be here, where I'd have my segmentations coming into my VAE, and then I'd have my classification model using that latent space. So I'd have various losses that would be incurred as my base model. But to include the uncertainty aware training, I'd add an extra leg where I was trying to model this weighting or loss and adding it into my base model, such that I would then heavily penalize my incorrect, highly confident predictions. So in terms of the approaches and strategies, I have 3 novel, and I compare them against 3 kind of state-of-the-art approaches that I found in literature. The first 3 are mine on the left, the novel ones. Those are the paired confidence loss, the probability loss, and the weighting. And the 3 that I also speak to in the slides follows was the accuracy versus uncertainty loss, a soft ECE loss, which I'll speak to because that's an acronym that'll come up in terms of calibration, and then a maximum mean calibration error. So the first uncertainty aware training approach that I had was paired confidence loss. So this was the novel loss. So here you'll see I've got my segmentation network, I have the VAE, and I've got the classification. And now with this aspect in terms of the loss, what I was doing is I was using pairs of samples. So utilizing pairs of samples, I think you often see people talk about true positive, false positive. So I had a table where I placed all of these samples, and then I derived a loss function such that it would actually penalize heavily in incorrect predictions if they had high confidences. The actual derivations for the formulas are in the paper, but they're quite detailed, so I thought maybe this would be the best approach. And then in terms of another approach we looked at was something called a probability loss. Here I was using a single sample per patient, but I was again heavily penalizing the incorrect predictions that were highly confident. But the main difference here was that I was doing it in terms of the ground truth samples, not my predictive probabilities. So even in the paper, it's quite explicit in terms of how I was deriving these formulas. The confidence rate, we thought, since we could actually utilize this latent space, we could sample from this latent space, and this way we create a weighting, and this weighting would be calculated in every training batch. And the idea was that we were utilizing percentages of the positive predictions from these samples, and that was giving me the confidence for the predictions. In terms of the state-of-the-art approaches, the first one, it was slightly similar to one of my approaches, but it was the accuracy versus uncertainty loss, and it was slightly different in the fact that they were trying to create differentiable losses based on the uncertainty that they inherently calculated while training the model. So that was quite slightly different. So again, they use single sample for each patient. Here, though, they had their table separating in terms of accurate and certain, and the inaccurate, certain, inaccurate, uncertain. So they created a loss function depending on that. They were counting the number of samples, so that was slightly different to ours. And the main thing was that it could be a differentiable loss term, so it could be included into the model with training as well. And then, have small increments or changes. The other strategy was the soft ECE. So that's one of the other state-of-the-art strategies. So the ECE is one of the metrics for expected calibration, called expected calibration error. And I'll get to that later because there's quite a few performance metrics that we looked at. But the idea was that if we could directly include this calibration loss in the model, what would it do? And could it help the model learn better? And here they had a single sample per patient. They also included other kind of temperature control bin functions. So what I'll show you now might look a little bit hectic, but the idea was that they wanted something smoother so that the model will slowly learn over time how to deal with these highly confident incorrect predictions. The last one that we looked at was something called the maximum mean calibration error. So again, this was by Kumar et al., but the idea here was slightly different. They used single sample for each patient, but they used something called a kernel-based approach. It was a differentiable loss, but in their paper, they actually mentioned that it would do well, if they had some adversarial perturbation, so kind of uncertainty. So that was something that we thought would be nice to look at, especially that this is what we want to achieve. We want to see how a model could better handle uncertainties as well. And they actually found in a lot of their work, and when we utilized it, you'll see the results, it shows some promising results in terms of better generalization. In terms of the material and methods, as you know, I said within the cardiology space, there's lots of various different types of applications. But in particular, I was looking at CAD and CRT. So CAD is for coronary artery disease, and that contributes to heart failure, as I mentioned here, where that's where the heart is unable to pump blood around the body properly. And then I also looked at CRT, so that's cardiac resynchronization therapy, and that's an established treatment for advanced heart failure patients. So this was just kind of a table to summarize the fact that we had different data for our two applications, and the fact that our CRT data was quite small. So we used nested cross-validation with that application, and also the fact that when we had the segmentation model, the data that we were training there, the initial pre-train model, that was different from all the other data that we used. So that was something we wanted to make clear as well in the paper. So now, going to the performance metrics, so we were looking at calibration. That was something we were interested in, and how would we measure it? So often you'd see in literature, I'm not sure if you have, but you would see that people talk about the expected calibration error. So that's the way in which it looks at the relationship between that accuracy and the confidence, which we spoke about in the initial slides as well. But the best way I often like to look at it is through a reliability diagram. So this is how it looks here at the bottom. And how this actually came to be quite important and people started considering was that there was a paper by Gao et al. And he was looking at a very simple network versus a more complex deep network, or a network versus ResNet. And what he was doing is he was plotting this relationship between the accuracy and confidence of samples. And what he found was that gray line is perfect calibration, we found that in the simpler models, it was quite well calibrated, so that accuracy and the confidence were matching one another. But in a very complicated model, that wasn't the case. And this is where this need to kind of look at calibration and consider it in our models became quite important, and it's progressed as well. But with the single metric, we actually thought, we need a wide range of metrics because often this is often seen as kind of biased because you create equal size bins and number of samples you have might not always be the same depending on application. So we decided to include other metrics as well and evaluate it. So there's something called the overconfidence error, or OE, and that's specifically looking at EC, but only when your confidence exceeds your accuracy. So we thought, that could be quite important, especially if when doctors want to utilize models that are showing these calibration metrics and they want to analyze which one they will use. Maybe they want some sort of cutoff, so this would be quite important for them. And then we said we'd also include the maximum calibration error, and that's something we saw, which is also included in some papers. That's looking at the highest gap over all the bins, so over all these confidence bins. And the bias score, we included it because we saw some papers where utilizing it as a metric to evaluate their models, but it's essentially similar to the EC, but it's the mean square difference between your predicted probability and the actual outcome or accuracy. And then, looking a bit further, because we wanted to be completely thorough in our analysis and try and include as much or as many metrics as possible, and we realized the ECE, we know it's quite biased, but it's often used, but we thought we could look for something alternate. And that's when we saw something called the AECE. So normally with the ECE, as I mentioned before, you have these equal size bins, but the AECE is something called an adaptive ECE. And essentially what happens here is that the number of samples in your bin is adapted to the distribution of samples in the confidence range. So what that produces then is a diagram that doesn't have equal size bins, but rather is accordingly placed by the number of samples. So you can see you'd have fatter, thinner bins. So it's tend to be less biased. So we decided to include that into our evaluation. And now in terms of the results, there's quite a bit, but we decided to start with the baseline. So often we always look at accuracy. So we said, let's look at that. And are there some improvements? So here you'll see I have the baseline model, which we said doesn't have any uncertainty aware training. And then you compare it against each of those strategies we presented earlier. So the paired confidence loss, the probability loss, confidence weights, accuracy versus uncertainty. And these two were in particular looking at calibration as being included in part of the loss. And then for the two applications. And what we noticed is that for the confidence weight, you do see that from the baseline, and it does show some improvement in terms of this balance accuracy. And that was the case for both the CRT and the CAD. But then we said, now it's quite a busy slide, but let's look at all these metrics that we mentioned, and does the same occur when you look at that? So we did see that with CRT and both CAD, we did see that the confidence weight actually did the best, and it did improve for both the EEC and the AECE. But interestingly, when you look at things, when you isolate other calibration metrics, see the MCE didn't actually do that well. There was a slight increase when we looked at the confidence weighting. And then we said, okay, maybe we need to also look at some of the AECE in a bit more detail, so visualize it. And we chose CAD mainly because we had a lot more samples, so we hopefully would see some noticeable changes. So here you have the baseline model, and you can actually see, so the oranges are overconfident bands. Within these high confidence ranges, actually it's quite overconfident for the baseline model, but once we start including things like the paired confidence loss, you start seeing these changes of movement in the samples. And noticeably, as with the results we showed earlier, you do see the biggest change when we utilize the confidence weighting. So this was something which we thought was quite promising, the fact that you can have this movement of samples just by including some sort of awareness training in your model. But they potentially obviously need some further improvement because you ideally want your really confident predictions not to be so overconfident if they're incorrect. And then what we said is, I spoke a lot about the uncertainty and how we were modeling it. So we wanted to kind of propagate that uncertainty and look at how that affected our calibration. So by doing that, again, we utilized all of these evaluation metrics, and we said, how does that look for the CAD application? And with the CAD application, the confidence weight did quite well, again, with the ECE and the AECE metrics. Interestingly, the soft ECE loss, which maybe because of the fact that it's considering directly calibration relationship, also did go up, but in particular for overconfidence error. With the electoric part of it, we did see that it was confidence weight again that seemed to keep it the same, but it had some lowering of other metrics that you see in the MC and the prior score. And then with the CRT, we noticed that was slightly different. I mean, it looked like the probability loss here, the strategy seemed to do better in terms of the calibration. But with AEC, it was the confidence weight. So again, it maybe highlights the fact that there's not one single metric that was giving us the optimal model. So that was quite interesting. And if it was overconfidence error, and that was maybe something of interest for this particular application for the clinician, then you would potentially want to include something like paired confidence loss. Interestingly, when we looked at the electoric, you use that electoric uncertainty and looked at how that affected the calibration, you noticed that the Brier score was the one that reduced a lot for the probability loss, but the soft ECE loss actually gave the best ECE value, and the accuracy versus uncertainty loss as well. So the thing with this was, I mean, we had very few patients. It was about 73 of those CRT patients that we had in the end. So we thought, we would consider the CAD model to be potentially better statistically significant because of the number of samples. So we decided to then perform additional experiments. And what we wanted to see was often when we choose our models with the validation set, we say it's the highest or the highest accuracy that we want. And in that way, we utilize that model and then we do some evaluation with our test set. So what we tried to do here is we were looking at test accuracy, but looked at how that changed if we had chosen the model based on the blue bars, which are validation accuracy, or the orange bars, which is validation ECE. So it was quite interesting. It looked like our confidence weights, and so far we've seen that that's been performing well in terms of results, had reasonably about the same test accuracy. But interestingly, if you're using the AVUC strategy, you saw that if you chose the validation ECE, that would give you a better test accuracy. And that could be noticeably because of the nature of the formula itself, but it was an interesting observation. So in terms of discussing these results, I think the main thing we did see was that consistently across the experiments we were forming, the confidence weights seem to be the most optimal performing, and then soft ECE as well, depending on the metric. So that was interesting. The fact that the selection of the model did change the final test accuracy, that was something we didn't think would make such a big difference, but it did. So that was interesting. And the fact that I think, just in general, if I put all the points up, is that defining the best approach is something that's not easy. So it depends on your architecture, depends on what metric as well, if you're looking at the evaluation that's most important. But the idea is that you have to start considering all of these metrics, all of these kind of approaches, because we need a lot more kind of transparency in these models so that we can actually trust them. And this is just the first step. There's lots of other ways in which you can do that as well, by visualizing on diagrams, which they often do when you look at like segmentation applications and uncertainty maps. But I think I just wanted to highlight before I finish is some alternate approaches of future work, if maybe you're also considering looking at uncertainty in your model. And the fact is that while looking at calibration, maybe it's also important to look at how you can create better kind of uncertainty estimates. So maybe even our approach to how we build these models is to think beyond the performance as accuracy and think of this uncertainty. And maybe there's quite a few points, but I think the first thing I start with is that maybe we need to reconsider our architectures. So build them in such a way that they can produce both uncertainties and accuracies. So you create a model that's actually giving you much more information, something that's a lot more useful to a clinician. If you also within this field, maybe look at something called deterministic networks. That's been something that's been of interest because it's single pass, doesn't take as long as if you were trying to build many models and evaluating or ensembling over those models. And then I think what was also interesting was the fact that the metrics weren't all consistent, and that was something that I've also noticed in a few papers where some people might utilize one metric or another, but that could make a big difference, especially when we look at our deep learning models. So maybe consider a lot more metrics in your analysis. And there was something also interesting. I specifically looked at uncertainty and how that affected calibration, but could also go one step further to see how you can disentangle that and look at which uncertainty is affecting your model most, and does it also align with what a clinician does on a daily basis. And I also think something that we should maybe consider is how do we even evaluate how we do this theoretically with a clinician, because we don't actually have some sort of baseline uncertainty metric to work against. So we actually just showing you what we can with our model. So that was quite interesting. There's some other kind of back and forth that we potentially need in this field as well with regards to that. And I was also only focusing specifically on images. So if you bring in other inputs and other data, how does that change the uncertainty? So there's quite a vast amount of opportunity in this field and exploration. But yeah, I think with that, I'd like to say thank you, and especially to my supervisors who've been really encouraging and helpful. The opportunity, of course, from all of my funders and sponsors. And I usually always end with one or two quotations. The one I liked for today was medicine is a science of uncertainty and art of probability. So that speaks to a lot of people, I hope, and I think. But also the fact that all uncertainty is fruitful so long as it is accompanied by the wish to understand, which I think speaks to research in general. So yeah, thank you.
Thank you so much, Taryn. A brilliant talk. Very, very, very interesting. I'd like to know if there is anyone who would like to make a comment or any question in the audience. Just please type it in the chat or raise your hand. Diana, please. Yes, go ahead.
Hi. Thank you very much. That was like really interesting, and I really enjoyed the talk. I think that my kind of general thoughts is that I guess that specifically for the imaging data, you do need to have some deep models, and unlike some regressions, which are by default track the prevalence that you see. So, for example, like any logistic regression or any Cox model, it will have the calibration built into the model. So when you actually fit the model, you actually fit to the calibration. And like most of neural networks, they wouldn't have it. And I think that I really like the idea of bringing this back to neural networks, maybe as an addition. Like right now, what you're talking is that you use some kind of baseline model, a state-of-the-art model, and then on top of that, you try to make it aware of the mistakes in terms of calibration. I guess that in the future, there will be more architectures of neural network which will actually deal with that like straight away. So you don't need to like do this on top of that, you know, like to have this additional layer after. So I think that's probably one of my first thoughts. The other thought is though probably the opposite, is that what we try to do is we try to have the models which will be trustworthy, and that also means that people understand how they do that. And I think that if we have some state-of-the-art model and then on top we actually use this layer of making them aware of the calibration, I don't think that like overall that kind of helps to disentangle what it gives you at the end. So I guess some models which would take into account both interpretability and calibration in the way it's structured in its architecture, that could be really good. But thank you very much.
Yeah, no, I like that a lot, because I think the thing is this. I like the fact that you can make the model more knowledgeable, but as the architecture gets better, it will probably get more knowledgeable. But I think there's still that aspect as to what level. How do you gauge that against a clinician's certainty? And I think that's the part that I always still battle. I mean, you can show them certain parts of the network, but there's also a lot of things where we often see that maybe the network's not, it's showing you what it thinks it's learning, but when you give it something different, it's actually not correct. So it's about finding those cutoffs, and maybe having cutoffs might actually make that model more knowledgeable, so that we just focus on where the problems are. But I agree with you. I think it's very interesting to see where it's going to be going.
Thank you, Diana, and thank you for your answer, Taryn. I think there is another question by Samara. So please go ahead, Samara. I think we can hear you. You must be muted, maybe. Oh, yeah, no.
Yeah. Thank you, Taryn. Very thought-provoking presentation. I work with such models, and if you allow me, I will give you some comments. I like the approach you just presented. However, there are other aspects that you need to put in mind. So all of us want to make sure that the accuracy or the difference between the predicted output and the actual output is so small. There will be always error. And the issue with the deep learning is they are a black box. You don't know what's going on. They don't know how they select their parameters, especially you working with autoencoders and convolutional neural networks for the image classification. So you don't know what type of features does the model consider for its prediction. I saw you use the dropout method where you switch off some neurons in order to maintain a better generalization for learning for the learning rate. However, it is you might put in an account the problem of overfitting and underfitting. So because I believe, with maybe Raquel agree with me or the rest of the team, most of the models are pre-trained models, especially with the deep learning. You don't develop it yourself from scratch unless you've got these powerful computers and you've got like a free weekends to keep the model simulate the iterations. But again, the way of overfitting and underfitting is a crucial way, and also you can't define them, precisely. Again, could align with your title, which is uncertainty. So, but you want to reduce the level of uncertainty. There is no ideal model, but there is very low low ratio uncertainty in your model. And these could be managed through different factors. So you mentioned the matrix you are using. We have confusion matrix that we can use, especially for medical fields. The number of the ratio of false positive, false negatives, they are very good. Also, if you go with the deep learning model, you can go with the classification. You can go with random forest classification. They are wide box classifiers that you can see how the model can go through the probability selection with its features. This is what I believe you can go with. But again, it's very nice topic. Thank you very much. I really enjoyed it.
Thank you so much for your feedback. I appreciate it. I think it's such a vast topic that you can talk for days about the opportunity. I think the main thing I found is that even though I think it's nice if we can start having more metrics to understand what we're doing, because obviously there won't be a single bullet solution, but I think we still haven't passed that point where we just, it's still first, let's put the accuracy and the basic metrics and then decide to put something else. But then maybe we not getting the right architectures to give us what we want. But I agree with you. It's very interesting, but thank you.
You are muted.
Yeah.
Now I'm muted. So I was just saying thank you both. And if there is anyone else wanted to make any comment, question to Taryn, we still have time. Yes, there is another question from Daniel. Daniel, go ahead.
Hello, everyone, and thank you, Taryn, for the interesting talk. Apologies, I joined a bit late as I couldn't be in time here, but I might have missed this. Did you consider any method to evaluate the uncertainty using the basically combining Monte Carlo with dropout? Because I think you mentioned dropout as an operation used in your neural networks. But did you combine it with this simple method of Monte Carlo? Because it's one of the methods which permits to evaluate how uncertain is your prediction. That would be the first one. And the second, I've seen you use the variational autoencoders. And I was wondering about how did you choose the regularization parameter for the Kullback-Leibler divergence. I think I used it again in your modeling.
Yes. So maybe the first one. So initially when we started out, we thought we would be measuring the uncertainty, but what we utilized the Monte Carlo dropout was to just give us multiple segmentations. So we utilized different probabilities to like kind of drop out the network. So that was more just to give us variations in the inputs such that we can evaluate in terms of the calibration. So I think often people utilize the Monte Carlo dropout to give them the uncertainty. We were utilizing it to help us with the calibration evaluation. So we had a slightly different approach to that. And then in terms of the second point, I utilized optimization strategy. So I just had a range of values for that KL divergence, like a range of it, and then I had a grid optimization whereby it found the best model based on the validation accuracy. But for the care model, I was checking at, in terms of the best ECV, so the best calibration and the best accuracy. So I actually had an optimization strategy to find my hyperparameters. So it wasn't that I chose and ran, it just found it based on the best outcomes from the model.
And roughly where these values were placed?
I think for the kit, they were it was like 0.1. If I remember correctly, I had this a while back, but it's in the paper because I put all of the final parameters that were produced. It was like between small ranges because it was around 0.01 and 0.1, I think, around there. But I had a large band that I started with, so the models ran until it found the best one in terms of the accuracy, and then I put it into my paper.
So there was a very little regularization, basically, in your models. Mm-hmm.
I tried. I was also thinking maybe that if it would have been like higher, but I found that even when there was previous work with the same, because the people had used data before with the VAE, they hadn't done other aspects of the network. They also had quite a small value. So I'm not sure if it was that limitation of it, but those are the values that seem to be produced through the optimization strategy.
Thank you.
Although, sorry, just maybe to add one more thing was that the recent work that I've been doing, I've actually moved away from the VAE specifically, and I've tried to look more at deterministic networks, but just looking at it in terms of a baseline model as the ResNet. Because with these deterministic networks, I'm not promoting them, but it's just interesting because the way they've changed some of the structures of the neural networks using things like the spectral normalization layers in it, it allows them to look at uncertainty completely separately from the actual prediction, which I think is quite interesting. I don't fully think some of the evaluation is there yet, but it's quite an interesting approach as well. Just because of the fact that, you're just using a very simple kind of probability distribution with the VAE, it's the Gaussian. There's a lot of new things with evidential neural networks that actually utilize direct layer distributions and probability density functions, which are quite interesting. Just sorry to add on if that's kind of the work you're looking at.
Okay, thank you.
Thanks very much, both. Samara, you have any extra comment?
Yeah, it is just a quick thing that it came to my mind after what Daniel just said. So you are looking for uncertainty. You assuming the data is perfect and ready to go to the model. But what you do when you have imbalanced data? So you can think of something that you balance out the data with some techniques. And then after that, you can measure the significance of balancing that data. So oversampling or undersampling, you can use, for example, Matthew correlation matrix, something like this, as a result when you apply or you manage the imbalanced data with your model as well. So you're assuming the data is ready and perfect, but what if you don't have a perfect data?
Okay, I mean, because I guess when you're training it, you do you try to balance it with that weighting that you can put into the loss. But to actually measure it, that's a good point. I should actually look at that from that perspective. Thank you. I will.
Thank you, Samara. Thank you, Tareen. Any other question from the audience? I got also exactly the same point about the imbalancement in the outcomes. I think that can affect your results. So that's something definitely to look at. I have another comment actually about your calibration metrics. I think that many of the people in our audience might be thinking, okay, but I probably I'm not doing the calibration in the best way I could or the optimal way. And from a simpler sphere, you know that we want to do the things the best we can. And I was just thinking, okay, so you showed that as a calibration metrics, the ECE and the confidence weight tends to be the optimal choices for your data and the deep learning models. I was just trying to generalize this. I don't know if we can generalize this to other machine learning models. So how do you feel about it? How specific were your results to your data characteristics and deep learning, the models that you use? I don't know if you can answer this because probably you haven't done more simulations, but do you have a sense of how applicable this is?
Yeah, well, I think, I did release some code in GitHub with this paper, so I don't think it will be too hard. In my personal opinion, I think the confidence weight should be easy enough to put on if you've got some sort of loss in your model, which most of your deep learning models do, because you have to add it onto that classification loss. So I think you can include it. It's just that the confidence weight is based on that VAE because you're sampling and using that confidence. So you would have to have some sort of probabilistic nature in your architecture. So yeah, I guess if you're looking at deterministic and trying to include it, probably not. But then most of the time you're trying to compare probabilistic against, the Bayesian against deterministic. So I guess you could add it if you were using a probabilistic network for the uncertainty.
Makes sense. Thank you. Is there any other comment? Nothing else from the audience? Everyone happy? Okay, so if that's the case, we will give it for a finish. Thanks very much, Tareen. It has been a lovely lecture and very, very interesting discussion. Thanks everyone for taking part. It's very lively and interesting part of the talk. And yes, so thank you very much everyone also for attending. And we will be here the next month again in May with Dr. Lorena Escudero. She's from Cambridge and she will be working on AI and talking on AI for cancer research. It's promising to be very interesting as well. So have a lovely end of the day and we'll see you soon. And thank you again, Tareen. Very well done. Thank you.